Hello, everyone. This is Dr. Vasna Delic. I have been placing osteobiomedical implants, dental implants, for over 10 years. And today, we're going to talk about dental implant success and how do we achieve it. So, first of all, sometimes it can be pretty vague. What is success? And sometimes we can be hard on ourselves in determining when our cases are successful. But in a nutshell, from what I've experienced in the past with dental implants, no news is good news. So when the patient is happy and their function is restored, and then there's osseointegration, are the basic elements for determining when you have dental implant success. And so some of you may be asking, okay, well, how do we determine whether we placed an implant and it was successful? And again, that can be subjective to some point. But again, one of the elements you can look at is obviously osseointegration has to be a part of that. Restoration of function and aesthetics are all achievable goals when we're talking about implant treatment. Determine your factors to success prior to beginning your procedure on a patient. I used to look at a patient and think of all the negative setbacks, all the risks, and then it puts me in a binding situation where I'm not going to pursue this. But over the years, I've taken a different approach to my patients and looked at and said, okay, well, what are the elements for me to achieve success on this patient? And there's a lot of factors that play a role into helping us achieve a successful dental implant placement. Remember to keep the restoration in mind when you're placing a dental implant, because we want to expect long-term results, not just the osseointegration part. We want to expect long-term results for the patient. Also consider the expectations from the patient. Every patient is different. Some people just want to be able to chew with their denture, and helping them, placing a couple of implants to help support their removable prosthesis is all that they want to achieve. So we're going to hopefully get into the treatment planning part of achieving success with dental implant placement. That's a part of achieving success. We'll talk about placement technique. That also plays a role. And then I added patient instructions, even though it's not really part of placement technique, but patient instructions is crucial for the whole team to be involved in when we're considering success of a dental implant placement. Then we're going to talk about treating peri-implantitis. I put that into almost the same category as tackling bone loss. But if we can spot out peri-implantitis and nip it in the bud, it would lead us to a more favorable situation. And then question and answer period. So with treatment planning, we want to look at, when we're with treatment planning, we can do a quick patient screening, which involves a health history. Financial concerns are part of this category. The reason is, are we going to break this up into certain sections? Are we going to be considering completion as soon as we place that implant? If there are no financial concerns, we may be able to consider a one-stage implant and immediately restore it. Then we'll talk about case selection, which involves an oral examination, radiographs taken within 1 year. I will look at radiographs that are taken within 1 year. If they are older than 1 year, we will retake radiographs. Study models. I would do a lot of my cases with ridge mapping because I did not have 3D imaging. We'll look at bone quantity and quality. Quantity is both length and width. Quality is the density. And so within the treatment planning phase and the health history, we'll look at medications that we need to consider. Medications taken currently or within the past 2 to 3 weeks. Are we going to consider a drug holiday? And then blood thinners. Blood thinners and monoclonal antibodies, which is a fairly new thing. We'll see right now on advertisements, a lot of the medications, if you were to see their generic name, they'll end in MAB. These are monoclonal antibodies. Anything with AB at the end of the drug name, the generic name, will indicate some form of antibody. And these drugs are intended to either suppress or enhance genetic expression of a certain DNA or a certain organ system. But on a level of placing an implant for that initial 2-week phase, which is critical for vascularization, for implant healing, it may, depending on what organ system we're talking about, or depending on how the inflammatory response is after patients are taking these monoclonal antibodies, it's something to consider regarding that initial healing phase of the implant. Biphosphonate therapy, of course, that changes the bone structure and it makes it more mineralized, so harder to heal afterwards. Consider this only especially if the patient is taking an IV form of it. Usually the oral form is not such a consideration. Other health considerations are underlying health conditions, of course, cancer, diabetes, autoimmune diseases, cardiovascular issues. Timing of these procedures and staging is recommended when we're faced with underlying health conditions. Sometimes we need to consult with the patient's doctor. Emotional or anxiety concerns are somewhat challenging because they delay, they can make the whole treatment procedure a little bit difficult for the whole team and for yourself, because you want to concentrate on the procedure itself. In those cases, consider some mild anti-anxiolytics, something like lorazepam, or anything to a triazolam that has amnesiac effects. I would place patients on triazolam 0.25 milligrams. And again, make sure you have the patient consent to a ride, that they're going to have a ride to the dental office. Prepare the list of medications for the patient and give them, these are the antibiotics and the analgesics you'll be giving them post-operatively. Prepare all of that for the patient and give them the option of starting the antibiotic the day of the procedure, in the morning, for instance, so that it'll lead to less no-shows. Consider the physical availability of patient. I remember one time I placed 2 implants on it was immediate placements after an extraction on a traveling salesman, and it was hard for me to do follow-ups with him. So treatment planning, patient screening, financial considerations, make financial options available. The more you're able to get this set in stone, the more you'll be confident when you're approaching your dental procedure with the patient. If you can break the payments up into phases, that will work for you and the patient. So oral examination, things to look at, jaw opening. Jaw opening can be challenging, especially when you're introducing some long dental tools in their mouths. The way I would help or alleviate this is asking the patient to open only when I'm approaching them with certain tools that are longer, and warn them ahead of time. Masticatory muscle tenderness, if present, check for that. Attrition, wear facets, bruxism, occlusal guards should be fabricated ahead of the temporary or final restoration. That will give them the opportunity to use it and get familiar with it. These are signs that the patient has tremendous force on their teeth. If they're going to have tremendous force on their teeth, they're going to have tremendous force on the implant that you provide for them. Tongue thrust and other oral habits are a nuisance, and they are, especially on the lateral forces on a dental implant. Tongue thrust alone can lead to a dental implant that's displaced on a patient. Presence or absence of teeth, occlusion, and any interferences. Presence of pathologic disorders of the soft tissues of the mandible and the maxilla. You're going to look at the width of your keratinized gingiva on the edentulous region that you'll be approaching. And so you're going to see where your unattached level of gingiva starts, and consider that, because that will determine the bioform health of that dental implant, and then the health of the remaining dentition. That's something to consider. Especially on a lot of our patients, we will see deteriorating dental health, but it will happen in stages. So kind of prepare the patient that, okay, we'll be placing an implant here, but what is the time frame for the other tooth on the other side? When are we going to be dealing with that one? Also, the oral pathologies of adjacent teeth can affect the implant that you place in the edentulous region. So that can affect the health and the inflammation in that area. Palpation of the ridge, you're going to do this to identify the contour of the labial and the lingual cortical bone. And then you're going to also be looking at that even as you're placing your implant, you're going to be constantly palpating that. And then the location of the myohyoid ridge, the estimated width of the crestal bone, you're going to be looking at all of that. And then the contour of the edentulous posterior mandible and the maxilla. The contour is important because it can also determine your interarch space between the edentulous ridge and the opposing occlusion. Remember, if there is a lot of a gap, that's going to, even though you do have appropriate height of bone to place an implant, that's going to inhibit your crown to root or your implant length ratio. And I've seen a lot of cases where you can place an 8 millimeter or a 10 millimeter length of implant, but then your crown is greater than 10 millimeters. So that doesn't lead to a favorable force on that implant. So as I said, X-rays should have been taken within 1 year so that you have a pretty recent outlook on the edentulous area that you're going to be approaching. Also, with radiography, you're going to be looking at vital structures and the radiographic landmarks. Some of them include, and this is a good example of what I mean by crown to implant length ratio. As we look at this one area, you still have maybe about 8 millimeters of bone. If you go into the sinus by about 2 millimeters, you can actually put a 10 millimeter implant here. And even the width of bone if it's available for a 5 millimeter diameter implant, you can have an ideal implant placed here, but the crown to implant ratio, your crown height is going to be this length, and that doesn't lead to a favorable occlusal force on that implant. And then so you can, with 3D imaging, you have a lot of more resources available here. You can look at the width, you can look at where the vital structures are, do a lot more pre-treatment planning with 3D imaging. And some of the landmarks you have to look at are the inferior alveolar nerve, the mental nerve, the mental foramen, and then for the maxilla, you're going to be looking at the sinus floor, the incisive foramen. This is just, I think one of the slides here. The incisive foramen and sorry. Okay, so for the maxilla, we're going to be looking at the sinus floor, the incisive foramen, and the nasal floor. And to be sure, stay 2 millimeters away from any vital structure and 5 millimeters anterior to the mental foramen, because in 30% of the population, we have an occurrence of the anterior loop of the mental nerve. And so when we're planning with our 3D imaging, you can actually see where you can place, you have that freedom to know where your ideal implant placement is relative to that anterior loop. And then here we can actually see in a 3D imaging, when you're taking these transverse slices in 1 millimeter sections, you actually see the mental foramen protrude there. So in relative to the mental foramen, you have you could see how you place your implant there. You can actually see the diameter and the length that you have freedom to choose for your implant size. I would traditionally do my implant selection based on ridge mapping. And even though one of the conventional ways is to use a Bowley gauge, you would look at the width with width of the ridge with the Bowley gauge. You take a measurement of that. You take your needle and you numb up the patient, find the width of tissue that you have, and then you take your study models and you will place your gingiva. You will map your gingiva, and then you'll have some idea of the width of bone that you have to work with. Now, just bear in mind that it does not tell you the quality of the bone or whether there are any defects within the ridge. The ridge mapping caliper is what I would use typically at the day of surgery. I actually have that available so that I can constantly feel that ridge area. It kind of tells me whether there's any cortical defects in the buccal plate, for instance. So here we have the preoperative view of panorex on a patient. And some things that you'll be looking at is, yes, there's your inferior alveolar nerve. There's also an impacted canine, horizontal impaction of a canine here on the lower arch. And then any areas here, any areas that might be suspicious of periapical infections. So I would use my panoramic stencils, and these are basically transparent stencils I would place directly on my panorex, and it gives you a 25% of a prediction over actual size. But and so when you place it on your radiograph, it kind of looks like this, where you can see where your implant would be placed, but in a 2D version. So bone densities are something to consider when we're looking at treatment planning. We do want to decide our implant type and size is going to be guided by our bone density as well and what we have available. Typically on the lower anterior region, we'll get D1, which is cortical bone and has low flexibility. I also put grafted bone in this category, although grafted bone has no flexibility. Keep that in mind, and has little vasculature. So class 2 or D2 bone is usually found in the lower posterior region and has a little bit more spongier bone. Class 3 bone or D3 bone is in the upper anteriors is usually found, and D4 and class 4 bone is located in the upper posterior regions, and that's usually spongy bone and flexible bone. These are the ones, this type of bone you'll have to consider. I would like to have people consider having a inventory of dental implants, because sometimes when we go in with our osteotomy, we'll find out that there's not a lot of resistance at all, and we might change our mind to using osteotomes, and then maybe using a lower diameter drill as our last osteotomy, so that we can place our implant with sufficient torque. So, mentioning torque, another measure of value for torque is the resonant frequency analysis. It's good to have one of those on hand, although I would use my torque wrench to determine the initial stability of my implant. Another way to determine the stability of your implant would be to use RFA tools, which measure the frequency at which an object vibrates when a mechanical stimulus is applied. The other, we call this the implant stability quotient, and these values are obtained using RFA. So some tools that measure ISQ or RFA is the Austell reader and the Penguin. And the ISQ values of 65 and greater is a good indication when to load a dental implant. And then an Austell has a separate attachment that is screwed onto the dental implant almost as an abutment. And so we call this the peg, the smart peg. And the reading is taken from this attachment, from the smart peg. The Penguin is a one-piece device, and it takes the reading right off the healing cap directly. So a perio test is a device you can use when the implant has a restoration on it already. So you don't have access to placing a smart peg on there. And so you, and in case like a one-piece implant, or when you have a crown on a dental implant. So the Austell reader is it actually can program patient's name, has all the information on there. Again, you'll have to use a smart peg, just like this, to detect whether to detect the ISQ reading. Now the penguin. So here we have the bone level implants with the smart peg. And then we have 68 as the reading, and we can place a temporary on there right now. So the penguin, sorry, it actually as well uses a smart peg to be able to detect the ISQ reading. So, but it's a one piece, it's very user friendly, and it's cordless. So if a crown is present, then we can use a perio test. And this uses some lateral pressure on the implant crown. But the torque value is what I would typically use to identify whether we have sufficient torque to put a temporary on there on the dental implant. So a placement technique, also, I want to go into like anything from start to finish with the procedure on a patient. One of the things I would remember is it'd be very distracting when I started a dental implant procedure on a patient and one of my team members would come and get me for a dental check. You know, I would prefer devoting my entire time to the task on hand, and I didn't want to see other patients at the same time, because the timing with the patient that when we're placing a dental implant is critical. We want to use sufficient irrigation. Run the unit before the patient is seen in the operatory. The last thing you want to find out is right when you're placing your implant that you're not getting any irrigation. Something is stuck in the system. All tools necessary should be placed in 1 or 2 different trays, ready for use and accessible. Sterile saline versus sterile water. Although I have used sterile water before, it's a lot more inflammatory for the tissues. So keep in mind, sterile saline is more of the pH value of your surrounding tissues, and at least to less burden on the tissues to heal initially at the initial stage. Know the difference between internal versus external irrigation. Our Osseo-Biomedical, our osteotomy formers have the potential to place internal irrigation in them, which is vital for D1, D2 bone. Local versus a block anesthesia. I know that when you're placing a dental implant in a traumatic extraction site, right, immediately, you're going to be using blocks for the lower mandible. But if you are going in into a healed site and you're placing your implant in the lower mandible, try to just use local anesthetic infiltration in that area. The reason is the patient will let you know when the drill is close to the nerve. If you're and there's no real concern for any kind of feeling on the patient's part, because in the bone in the bone part, there's no nerves for the patient to feel any drilling. So keep the surgical site as clean as possible. So avoid periapical lesions in the adjacent teeth areas with infected adjacent teeth. And then also avoid or minimize saliva contamination in that area. Choice of tissue level implant versus bone level implant. You have a choice between the two of them. I would prefer tissue level implants because they can be bioactive, accelerating osseointegration. And then tissue level implants also have the added benefit of optimal long-term bioform when you're considering the implant to abutment junction. So when we say bioactive, is that embedded tapered platform, which pulls on the bone here, puts tension on the bone. And then also the auger nose tip here, the bull nose tip, will compress the bone. Both of these forces are ideal in forming the bone lining cells when they originally form, to place them in a favorable alignment with the masticatory forces. So the tissue level implants also have the added benefit of the bioform. When you're considering the implant to abutment junction, what we mean by that is, in this case, this is a one-piece implant, so I'm really not able to show you here, but let's say a two-piece implant would have the crown and bridge start right here. And so that's the area where you have potential microbiota, a challenge there, and inflammation, but it's accessible to the patient to clean. So you'll be maintaining the stability of the critical part, which is right here where the microthreads start. So are you going to be lifting a flap, or is it going to be a flapless approach? That's a question that you'll be considering. Maybe even at the time that you see the patient, you were planning to lifting a flap. You're planning on lifting a flap, and you realize you can probably do this in the flapless approach. Check the alignment. Make sure that you use your paralleling pin if necessary, and then realign. Sometimes you're not going to like your alignment, and so you have an opportunity to realign with your number 8 high-speed round burr and your pilot drill to get through that tough crestal or cortical bone. And then keep the restorative portion in focus. So you're going to, when you place your paralleling pin, you can actually see an idea of where the final restoration is going to go. So what can happen is if we have a misalignment, especially with immediate placements after an extraction, it may lead to a difficult restorative situation, but not entirely impossible. And sometimes they can look misaligned, but when you're actually looking in the patient's mouth, or they even look misaligned on the study model, but actually when you're looking at it occlusally and in the patient's mouth, it actually turns out pretty reasonable. So that's why that paralleling pin is important, to look at that angle. Remember to keep your ideal parameters of bone. You do want to have at least 1.5 millimeters of bone around that implant. When we're looking at 2 implants in the bone, we want to have at least 3 millimeters of bone. You don't want to have any visible penetration of that or tactile penetration of that implant body through the gingiva or the cortical plate if it's flapless. So, and you don't see the implant or no penetration through the cortical plate if the flap is lifted. So during the procedure, if it's a flapless procedure, place your index finger along the lingual and the labial sides or the buccal sides, and your thumb on the buccal wall to feel for the vibration of the drill. That can be a guide to how much bone you have to work with on the buccal, around that buccal plate or on the lingual wall. But if a perforation does occur, you can lift a flap, place some bone grafting material, collagen membrane if necessary, and close the suture with primary closure if possible. So another, I put the bone density to consider as well with the placement technique, because if you are dealing with spongy bone, you have the opportunity to go down diameter with your final osteotomy drills so that you can increase your torque value. But avoid an insertion torque of greater than 60 Newton centimeters. That can cause strain on the bone. And so you may want to sequence your drills if necessary in these cases with D1 bone. If a torque value is 35 to 55 Newton centimeters, that's ideal. Okay, if the torque value is lower than 35 Newton centimeters and above 10 Newton centimeters, make it a 2-stage dental implant with no primary loading capability. All threads are not visible, okay, and are within the crestal bone. If you do see some threads and you're at your final length, what I suggest to do is take out the implant, go back in with your pilot drill deeper and your osteotomy former, and get to where you're going. Remember to use your countersink drill because that will ensure that all the threads are 360 degrees into the bone around that implant. The torque is achieved and the implant is not implanted into sufficient, and like I said, if that happens, when you achieve your torque, but you feel like you've already bottomed out, remove your implant, reestablish your pilot depth a little longer and with your osteotomy former, and retie in your implant. Something I do when I feel like I'm close to vital structures, I will take x-rays and see how much space I have. And then if it allows me to do so, I will go deeper by 2 millimeter segments to achieve my goal. And again, another suggestion that we can make on behalf of OCO Biomedical is keep an inventory of dental implant sizes available for you in case you change your mind. You'll be able to establish the dental implant that you're working with as soon as you get in with your osteotomy former. Feel for that quality of bone, understand the different densities tactily. So if the torque is lower than 10 Newton centimeters with no stability achieved, and there's room for an increase in diameter of an implant, go up 1 millimeter in diameter. Let's say you have a vital structure, but you do have, at the apex of the implant, but you do have leeway in terms of the diameter of the implant. Go up 1 millimeter in diameter. And remember, sometimes osteotomes can be used, actually most of the time in the maxilla with D2 and D3 bone, so that you can better adapt your implant with higher initial torque values. Use sharp instruments. Keep track of the number of times the same drills were used. And so we created a drill usage chart for everyone to kind of keep track of their drills in use, and have your teams all play a role with this. So before they go and sterilize, they're going to mark off the drills that were used. Patient instructions I put as a part of placement technique because this involves the whole team. And we want to be consistent on this because we want to take steps to avoid the Bill Murray scenario in, I forgot what that movie was, but he kept on, he needed to be with his psychiatrist 24/7. And so it would lead to less phone calls and when you involve the whole team. And then analgesics, the NSAIDs and acetaminophen, cold compresses, antibiotics, and amoxicillin, Keflex, azithromycin. Consider any allergies. You want to place patients on rinses, Clocis, chlorhexidine, oral hygiene instruction, the gentle brushing. You can demonstrate the pressure, avoid that area when eating. Occlusal guard is ready for the patient to be using. And so have a team member accompany the patient to the front kiosk, make an evening call, personally make an evening call to check up on the patient, and be ready to answer the usual questions. So patient has returned to normal sensation and can have slight discomfort and some bruising. I've had some patients, some older ladies who would end up with bruising along their whole lower mandible there along the cheek. More discomfort is normal with an immediate placement with an extraction, okay? Make a 24-hour post-op appointment when you feel it is necessary. For instance, the patient may have had some bleeding issues or be on a lot of medications, or you may choose to bring in the patient earlier than expected for any of the following reasons when you question oral hygiene or to re-cement a temporary, feel like that might have been dislodged. So you want to irrigate with chlorhexidine. You want to re-cement the temporary for the patient, and then go over any of the customized instructions for this for the patient. 1 to 2 weeks after the placement of a dental implant, let's say the patient has not called the office within 1 week. That's good news. However, sometimes we do want to make a 1 week post-op appointment for the patient. Again, this is more for the patient than for yourself. Just to make sure that they've gone through instructions. You also want to just check up on the area that they're, there is no inflammation for any patients of concern. And then so if you are going to be bringing them in after 2 weeks, you don't see any visible signs of mobility, no gingival inflammation, or is minimal or not present. And then emphasize to the patient the importance of rinses and gentle brushing. So let's say you do see some inflammation around the implant. You don't see any bone loss. There's none of it evident according to your x-ray. And obviously no mobility of your implant. You're going to go through the oral hygiene instruction. Again, your team can help you with this. They are also going to be prescribing, or they're going to be handing out Closis, and you're going to be prescribing chlorhexidine. And then we could talk about Hibiclens soap at the end. That is pretty much chlorhexidine gluconate, but it's a 4% solution. You can prescribe them Augmentin, combination of Augmentin and Flagyl if it's a constant problem that you see with them with peri-implantitis. I would try to nip it in the bud with Augmentin and Flagyl. Another solution I would recommend to my patients, and I would just recommend this on a daily, well, not a daily basis, like a weekly basis at least for my perio patients. But if we do see an issue with implants like peri-implantitis, then we can recommend it for them as well on a daily basis. And that the Dakin solution, it's not really technically a Dakin solution because we didn't have any boric acid in there. It was a World War I remedy where they found, and this is before the introduction of antibiotics, they found that a certain level of sodium hypochlorite really helped with wound healing, but did not destroy the white blood cells. So in this case, a teaspoon of sodium hypochlorite, which is bleach, and 8 ounces of water will do the same. It won't destroy healthy cells, but it will kill all the bad bugs. And so let's say we are tackling bone loss right now. We see our implant, there's no mobility, but we do see that there's a challenge with bone loss. And adjunctively, I'm just going to say, when 70% of the population has some form of periodontitis, and so it's never going to be healed. It's going to just be treated long-term. And so we're going to be tackling the same problems with these patients if they have periodontal disease beforehand and afterwards. All we can do is help manage it with these patients. I do recommend that before you start a procedure that you get patients, that we get patients on a periodontal regimen where we can actually see healthy tissue before we place an implant in there. And so let's say we are tackling bone loss and there is no mobility. We want to check for any interference, any kind of occlusal interferences. What is the general occlusal scheme? Was there changes in the occlusion? Did they lose a tooth during this procedure anywhere else in their arch? How about progressive excursions? Sometimes I'll have to demonstrate to patients how to do lateral excursions, how to, grind and really establish the markings with their articulating paper, with our articulating paper. Occlusal guard, we want to stress that to anybody getting a dental implant. I'd say an occlusal guard is a must. Fabricate that for them if you want to include that in their initial fees. Bone grafting after debridement and irrigation. Okay, that's something to consider as well. We can do that if we feel that we can, if it's conducive for that region. Go over oral hygiene instruction, place them on Closis, consider Augmentin and Flagyl, and the Dakin solution. So what happens now? There's bone loss and there's mobility. So this could be attributed to anything. We see adjacent root canal therapy that could have had some periapical lesions that we don't see radiographically, but that could have affected this implant. We don't see the buccal and lingual width of bone whether there was fenestration. Also, we don't know the health of the patient here. There could be iatrogenic causes to the mobility of this implant and the bone loss. For instance, underlying health issues. Could have left that. Prednisone is one drug that can inhibit the normal inflammatory process to the initial healing phase of a dental implant. So consider that. I had a patient who had a long time, it took him a long time to heal. And the only thing I could rule out in his health history was he was on Neurontin or gabapentin. So these are some of the medications that we just don't know. Again, that's why follow-ups with patients determine what we can do to help in those situations. And again, segmented or phasing out of the treatment plan is helpful in some cases. Let's say we're tackling bone loss and there is mobility. It's not the end of the world. We can take an X-ray which shows whether there is radiolucency around the implant. Again, check for infected adjacent teeth. That might be the culprit, okay? Address those. If the implant shows signs of gingival inflammation and the implant is mobile, consider removing the implant under local anesthetic at this visit and debriding the area with irrigation and either grafting with full closure or placing another implant, one diameter size up or in length, if no fenestration is visible, of course. But if there is no inflammation and the mobility is coming from the implant, check the occlusion. There's one time I've seen a patient on recall, the implant was mobile, I would say generally like a M2 mobility, and there was no pain. And he came back for about, I would say 3 to 4 recalls. And I'm looking at his excursions in the dental chair. And one time I remember calling him back, or he was in getting his cleaning, and I took a look at this implant. I believe it was a TSI, and there was no inflammation, nothing. And I said, you know what, Ted, I'm going to have you sit up and really rotate your jaw in all directions, and I would demonstrate to him how far I wanted his jaw to go in all directions. And lo and behold, there was one spot that had an interference on that crown. It was a zirconium crown. I adjusted it. The next time he came in, which was I think 3 months later, that implant was tight. There was no mobility noted. Okay, what if we're tackling bone loss without mobility? Well, we can follow up with the patient by placing them on a 3 to 6 month recall. We can encourage, let's say they're smoking, we can encourage them to quit smoking, maintain good health. Let's say the healthy gingiva is present, pink, and there may be some bunching that might be present around the tissue of the implant. Minimal or no bone loss is present. Well, these are the situations that we want to obtain. Minimal or no bone loss is present. Ideally, take an X-ray at a recall appointment just to verify this. But let's say there is a little bit of bone loss. This might be only a cosmetic issue, but check the occlusion and adjust as necessary. Review oral hygiene. Again, patients should be on frequent periodontal maintenance and recall programs. We might introduce the Delic solution or Closest, have them rinse with Closest, and show them how to use tools to make sure that they can clean between interproximally. So what does success after 5 years of placement of a dental implant look like? Well, there's no mobility, there's healthy gingiva, take an X-ray, minimal to no crestal bone loss. A patient, and I say patient has left the building, meaning no news is good news. Sometimes they don't return. But other situations to consider are this. Let's say you have no bone loss on the X-ray, but the crown is loose. And so that means that the screw that holds the crown, the abutment, is loose. How do you do this? How do you tackle this? Is you create an access hold for the screw, tighten it with a 0.05 hex wrench, place some cotton pellet and resin to close. And then, like I said, no bone loss, but the entire implant is loose. I mentioned that case already when check for the occlusion in these cases. So some cases of that we have on file here at OCO Biomedical are these cases. I believe this is over 5 years old. Patient comes in, has a deteriorating upper and lower arches. And so implants were placed, and choice of tissue level implants. This is like 3 years later, 5 years. The previous one was like about 2 years later, I would say. This was about 5 years later. And this is another case. Or let me just make sure here. No, this is the same case. Let me just make sure. Sorry. The same case. Okay. And as it progresses, again, tissue level implants here. There's one bone level here that was placed on the number 9 area. And it's held with a two-piece cantilever bridge. But again, you'll see a lot of these cases where patients will do things, you know, in segmented times, and one tooth will start falling apart on them. So you tackle that for them. This is another case. We have lower left area. And these are, again, our tissue level implants. And here are some more. And again, these are like, this one here, I believe, is 3 to 5 years later on the same patient. So this is what a TSI looks like at the day of surgery placed. And the microthreads are about this level here. So this is the embedded tapered platform. And this is all titanium nitride. So this is all smooth surface. So what you'll get with time is that bone will recede to that level of the microthreads, and that's healthy. So 3 months after placement, this is what it typically looks like. And you can see it here with this, with the TSI. Even though this is on an angle, that bone is cortical bone, and it stops right at the microthreads of the implant. This is 1 year post-placement on the lateral incisor, and it's using a ERI. This is an ERI. 6 years post-placement of a ISI. That's 10-year post-placement. This is one of my cases. This is a 4x10 TSI. Went into the sinus a little bit there. And this is what it looks like 10 years post-operatively. Tissue level implants have really optimal bioform. It makes it, these tissue level implants make it easier for the patient to clean around their implant. Well, thank you very much. You've been a great audience. Any questions? Okay, you know what? There's a few things I could change, okay?